All right, so today I want to cover the topic of false negative testing. And I think it's, you know, fairly intuitive that most people, if they get a false negative test, trust the result and say, I don't have X, whatever X that was tested for. But I want you all to know that it's possible to have a false negative, and false negatives may be more common than you think. And all tests have false negatives and false positives. So there's no test that's 100% bulletproof. And it's important to understand the possibility of false negatives as well as false positives. But today we'll talk about false negatives and how to maybe unveil them if you've got one. So we'll talk about a false negative from a blood test perspective. We'll talk about a false negative example from a culture perspective. And we'll also talk about false negative from a biopsy perspective. And these are important because, again, you may have a test, especially in, I see chronic people who are suffering with chronic illness. And many times people have seen multiple doctors and had multiple tests, and the tests come back normal or negative, but they still feel crappy. And so they're frustrated because, they're saying, I feel terrible. The doctors are saying you're normal because the diagnostics are normal or negative. And so you might end up with an antidepressant or something because you're annoying to the doctor, and they don't necessarily discern the false negatives and don't know what else to do. So I think this video will be helpful for those patients out there who are suffering with chronic illness and potentially suffering from false negative testing. So let's start with biopsy. Now, a common biopsy that occurs is in the form of, we'll use an EGD test or an endoscopy. Okay, so they stick the tube down your throat and they're looking at your esophagus, they're looking at your stomach, and usually they're doing that if you have acid reflux or stomach issues of some sort. So here's a rough drawing of the stomach and a very short esophagus up there. Okay, but what happens is they stick the tube down your throat and down your esophagus and into your stomach, and they're going to biopsy a part of your stomach. And one reason they might be doing this is if you have acid reflux or gastroesophageal reflux disease, GERD is another name for it, or heartburn would be a lay name for it. One possible cause of that is Helicobacter pylori, or H. pylori. And H. pylori is a bacterium that loves to colonize the stomach and go in there and basically set up a colony and damage the parietal cells of the stomach. The parietal cells are the cells that make stomach acid. And so if H. pylori damages the parietal cells of the stomach, the parietal cells are the cells of your stomach that make stomach acid and help you digest protein. Well, acid is acidic, as the name implies, and so if you're producing less acid, it makes the stomach more alkaline, which is more hospitable for H. pylori, but not beneficial to you. So losing those stomach acid producing cells leads to lowered stomach acid, which leads to possibly a big steak or a big burger being maldigested. And if it's not digested well, the stomach connects to the small intestine. So the small intestine would be this way. And that steak or that burger might move into the small intestine, not well digested. And then in the small intestine, there's some proteases from the pancreas helping break it down further, but most of that breakdown should occur in the stomach. So if it's not occurring, that big protein lump might feel like a brick or a rock in your gut. And it can also become fermentative substrate for your bacteria and maybe lead to SIBO, to gas, bloating, diarrhea, constipation, etc. So you might just decide, hey, every time I eat meat, I do bad. I just can't eat meat. I'm going to be vegan or vegetarian. And you may suffer, because you made a decision thinking you react to meat where really you're not digesting it well, so you're having symptoms. Okay, so H. pylori can drive that. And so you might go, before you pull the vegan card or the vegetarian card, you may go see a gastroenterologist, and they may run an endoscopy on you to go look for H. pylori. And they'll say, hey, we'll go in there, we'll look around for gastritis, we'll see if there's any polyps in there, or a stomach ulcer, or gastric tumor. They're in there looking, so they'll look for those things. Is there any Barrett's esophagus or eosinophilic esophagitis? Different diseases they could find while they're in there. And they'll also say, well, while we're in there, we will biopsy for H. pylori. So they'll take a needle and they'll biopsy a part of your stomach. Okay, so that red arrow in this drawing would be the needle, and they'll take a sample of your stomach and they'll pull it back out, and they'll test it to see if there's any H. pylori. And so, oftentimes they'll say, hey, let me get my red back. They'll say, nope, your biopsy was negative. You don't have H. pylori. And so you leave saying, well, what the heck? I'm still having reflux. When I eat protein, it feels like a brick or a rock in there, and I'm not being helped. Well, in this scenario, that's a false negative, right? Because you can see this black patch here is H. pylori. But one of the problems with the testing is when you're taking a biopsy, they're literally cutting out a piece of your stomach lining. So the test is limited in how much stomach lining they can cut out, right? Because you need your stomach. So if you biopsy this area where we did, and you miss the actual H. pylori, which is right here, you get the correct result from the test that you were negative for H. pylori in that area that the test biopsied you in, but it's a false negative in that you do have H. pylori and it didn't find it. Okay, so you could go on suffering that way. Well, so that's the biopsy example, and we'll circle back to what could we do to avoid that in a little bit, but that's the biopsy example. Let's use a culture example, and a common issue here would be, say, a UTI. Okay, if you have a urinary tract infection, it's if a woman comes in or a man comes in and has, maybe urinary frequency, maybe burning or painful urination, those are signs and symptoms of potential urinary tract infection. So your doctor might run a urinalysis called a UA, and they might reflex it to culture, or they might just culture your urine straight up. There's two different ways to do it. You could run a urinalysis, and if there's markers in the urinalysis that suggest UTI, like there's high counts of bacteria or high levels of nitrites or white blood cells, then they could reflex it to culture, meaning, hey, if we find those things, then culture it. Or they might just head straight to culture. And so what they do on a culture is you have a petri dish with a certain medium on it, and they're going to take your urine and they're going to apply it to the petri dish, and they're going to culture it or see, does anything grow? Okay. And so if something grows or is culturable, that could end up being the culprit. So maybe E. coli is one common UTI causer. Okay. Or Enterococcus faecalis is another common one. Or Klebsiella pneumoniae is a common one. So there's many common microbes. Strep is another one. Common microbes that can cause UTI. Okay, so they'll culture it, and if they find it, then they can reflex that culture to sensitivity, where they actually test these microbes for what their sensitivity is to certain antibiotics. And then if, say you have an E. coli UTI, they'll reflex the sensitivity. And if it's sensitive to amoxicillin, then the doctor will prescribe amoxicillin to wipe it out. The sensitivity testing can say, hey, it's sensitive to amoxicillin, but it's not sensitive to, you know, doxycycline, say. Well, then they want to give you one that they're sensitive to, so you kill it. Okay, so in that case, hey, we were successful. We cultured the urine, we found the bug, and we killed it with either an antibiotic or a natural antimicrobial. Okay, so that would be a true positive culture. That would be what you hope for. But but with a culture, when you're putting bacteria on, or you're putting urine or whatever on a petri dish, that petri dish is in an oxygenated environment. Okay, so one issue there is with oxygen around, all that's going to grow on that petri dish are microbes that use oxygen. Okay, so you have the opportunity to find these things because they are aerobic bacteria, meaning they utilize oxygen to be grown. But one way that the culture could be negative is if you're infected with anaerobic bacteria. Anaerobic is just bacteria that do not live, they can't live in oxygenated environments because they don't utilize oxygen. And so if you have a UTI and you're having all those symptoms, or you have UTI symptoms and your urinalysis is showing evidence of an infection, but the culture is negative, it's possible that your doctor says, oh, culture was negative, don't worry about it. And you could chase some other reason as to why you're having those UTI symptoms. And if they don't, you know, think about it and realize, hey, the culture is only useful for aerobic bacteria, maybe this person has anaerobic bacteria, then those anaerobes persist and you stay infected. So in that case, that would be a false negative. The negative culture is really only negative for aerobes. It didn't check anaerobic species. Okay, so in the culture world, anaerobic isn't going to show up, so having a negative culture just rules out the the aerobic species. All right, and then in the blood, false negative testing in the blood, a fairly common possibility is when we're doing allergy testing in the blood. And so with allergy tests, we're using immunoglobulin E, or IgE for short. And immunoglobulins are antibodies, so you could say IgE or antibody E. But IgE antibodies are what allergists are going to test in your blood if you're looking for allergies to something. So if you were, say, allergic to pollen, they would run a pollen IgE to look for positivity there. Okay. If you were suspecting a wheat allergy, say, they could draw your blood and run wheat IgE or apple IgE or whatever IgE you want. Okay. So that testing is based on the IgE antibodies. When your allergist runs and typically they run a whole panel. So if they run an environmental panel, it would be, you know, oftentimes trees and weeds and grasses and molds and danders and cat and dog, right? And dust mites, things like that. A food panel might have common foods like wheat and dairy and corn and soy and chocolate and coffee and things like that. But to be reliable, most reliable and truly done correctly, you must run the total IgE in addition to the various antigens you're looking for allergens against. Okay, if you don't, then you have the potential for false negatives, because if you say you ran wheat and you ran dairy and you ran soy and you ran corn and you ran coffee and you ran chocolate, say, okay, all IgE. So that means you would have wheat IgE, dairy IgE, all specific IgE antibodies. And they were all negative. Well, your doctor might see that and say, hey, Sally, you're negative for all these antibodies. You don't have any wheat, dairy, soy, corn, etc. antibodies. But if they did not also include a total IgE in that test, then those could be false negatives. Okay. At LabCorp, the total IgE normal range is 6 to 495. Okay. So to truly believe that you don't have an allergy to one of these foods that were tested, you need a total IgE that was within this normal range somewhere. Okay. If your total IgE, say, was less than 6, or even if it was, less than 10, between 6 and 10 would be functionally low and questionable, but definitely less than 6, then your body isn't making enough IgE to even be able to show us a true positive when we test these, right? So if you have a total IgE of 5, say, that would be a lab low total IgE. And if all of these come back normal with a lab low IgE, we don't know, are they actually normal, or is your total IgE so low that you can't show us a true positive even if you have one? All right, so if you've had allergen testing and they didn't run a total IgE and they told you didn't have an allergy, but you have symptoms of allergy still, then there's potential there that was a false negative due to lab low IgE or your body's ability to not show a true positive. Okay, so these are 3 common testing methods that could yield false negatives for you and lead to continued suffering due to lack of understanding or optimal interpretation of the testing and what they mean. Okay, so what can we do about this? Well, one way to kind of help rule out false negatives is to test different assays or different methodologies. So we'll come back to this, but let's jump over to a research paper. So here's a research paper that is looking at fungal infections, okay, invasive fungal disease, and it's looking at biopsying for fungus, biopsying tissue to discover fungus in that tissue, and then using another test, a PCR test, to amplify DNA to find false negatives. Okay, so this will mean more in a second, but let's just look. They're using PCR tests to evaluate for invasive fungal diseases. They took 89 biopsy samples from 84 different patients with proven invasive fungal disease. Okay, so we have 84 patients in this study with proven fungal disease. So we know they have it. And so we're using them because we know they have it. So we want to see, well, what is the sensitivity of the testing methods we're using in finding a disease? Okay, sensitivity is what percentage of tests, what percentage of the time does the test you're using find disease X in someone with that disease? So we have 84 patients with known invasive fungal disease. So if our testing strategies were 100% sensitive, they would find invasive fungal disease in 100% of these people. Okay, 84 out of 84 of those tests would be positive. All right, so what do we find? They performed culture on 68 of those patients, and they did PCR testing as well in the patients. And so what they found was the sensitivities of PCR-based technique was 89%. Meaning if we run a PCR test for invasive fungal diseases on 84 of those patients, they find fungal disease positive in 89% of those patients. So essentially, there's 11% error rate in that test, okay? Whereas culture for fungus was positive only 56%. Okay, so we have 84 patients that we know 100% have fungal disease, but culture only finds it in 56% of people that we know absolutely have it. Okay, so that's about close to a 50-50 shot or a 50% error rate. All right, so if we jump down here, PCR was positive in 80% of cases with negative culture. Okay, so again, we just said we have 84 patients with proven fungal disease, but culture only showed us half of them. Let's just say half for easy communication. Okay, so we'll say half. So in 42 of them, we only found, we found in 42 people with known fungal disease, culture, or excuse me, in 84 people with known fungal disease, culture only found 42, just for easy math. Okay, well, of those 42 that were negative, PCR testing found 80% of them to have fungus. Okay, so what they did was these authors used the PCR test to kind of double check for negative culture. Okay, and then down here, in 5 cases, there was no correlation between culture results and PCR, indicating that there's a possibility of a mixed infection or the presence of colonizer contaminant microorganisms. So that means, hey, maybe the culture results and the PCR results aren't correlated. Maybe they both found different infections, okay, which is possible. And then the authors conclude with PCR-based techniques for DNA amplification should be implemented into histopathology and microbiology departments as they appear to be complementary to conventional methods. In other words, PCR testing should be added to microbiology labs, because if your main testing method is missing half of the diagnoses and the PCR can find it 80% of the times in the one you miss, you're going to serve that many more patients correctly. So I think this is a big deal, and it helps you understand that being told you don't have something based on one method doesn't necessarily mean it's not there. So if we jump back over to our drawing, what we just saw in the paper was that culture, this one missed, okay, missed, say 50% of the fungal infections. So they followed it up with a PCR test that found 80%, that found the infection 80% of the culture misses, right? So 80% for easy math, culture only found 42 out of 84 cases that were known to have it. 80% of 42, call it 42 minus 8 would be 54. So, or excuse me, 34. So 34 more patients were found and treated correctly when they added PCR to the culture test. Make sense? So in biopsy, with biopsies, I've done this with multiple patients. I've had patients with negative biopsies for H. pylori, but we run a stool PCR test for H. pylori, and that test is looking for DNA presence of H. pylori. So if there's DNA of H. pylori here, it'll come out in the stool, and then we know it's there. So even though there was a negative biopsy, because it only checked this area right here, the PCR test found DNA in the stool, and so we know H. pylori is there, and you can treat it instead of going on and suffering. So to wrap it up, when you're told you don't have something, you know, many times you truly don't have it. But if you're a chronic case that's been suffering and seen many doctors and they're not finding anything else, consideration of whether you've had a false negative is warranted, and running the test a different way with a different methodology that is shown to be maybe more sensitive and or specific may yield a different result and lead to, you know, a clinical target that can then be addressed, which can result in improved quality of life and healing for you.
I'll share my experience. I had a biopsy for celiac disease, which is supposed to be the gold standard.
Mm-hmm.
Well, first I had the the blood test for the antibodies, and that came back positive. And then they're like, well, let's do the small bowel biopsy because that's the gold standard. And if that's positive, then definitely you have celiac. Mine was negative. So the doctor was like, well, I don't know if you have celiac or not. And sure enough, I did. So
Yeah, so good point. Let me bring up an image for you here. This is an image from my book that helps explain what you went through. So let's switch over to that here once it comes up. My computer's taking a moment. Here we go. All right, so this is from my book, The Autoimmune Answer, for those who maybe haven't seen it. Can find it on Amazon. But what this chart is showing us, and let me zoom out a little bit. Yeah. Oh, that's as small that lets us make it. Okay. Can you see the diagnosis column, or are our heads blocking it? Everyone can see it? Okay. So Sue just said she was diagnosed with celiac disease, or she had celiac, the antibodies that are positive when celiac disease is in process. But then the gold standard diagnostic criteria of being diagnosed with celiac disease is a positive, a positive villus atrophy on small bowel biopsy. And so what they're looking at is if your small intestine has these things called villi, which if you look at me and my screen, my fingers represent the villi in your small intestine. And those fingers are useful because they provide surface area for increased digestion and breakdown. And these villi, it's also called the brush border. And this brush border releases what are called brush border enzymes to finish the digestive process. So you start digestion with chewing and salivary enzymes, you swallow, and then the stomach releases stomach acid and other things, and that goes into the small intestine. The pancreas dumps in pancreatic digestive enzymes, and it goes further down the small intestine, and things are broken down. And the last step is the brush border enzymes. So that's a healthy small intestine. Well, in celiac disease, you have what's called villus atrophy. And I walk through this in chapter 6 of my book, and there's different stages. It's called Marsh criteria of inflammation in celiac disease. And so there's different stages that equate to different levels of risk of death and things like that. So as the villi shrink, okay, or break down, you're worse off and you're digesting less and you have more GI inflammation, et cetera. And to the point where you have, say, 100% villus atrophy. And so instead of looking like my hand, it looks like my fist, okay? And so when they go in there and they're looking for the villus atrophy, if it doesn't look like this, they're basically saying you don't have celiac disease, even if there's some of this. It depends on the doctor, but and what Marsh criteria they're going by, but really this would be celiac disease, okay? That would fit diagnostic criteria, which you can see on the far viewers right of my chart here. But Sue didn't have that. Sue had antibodies, okay, and she had signs and symptoms, but until she fits the diagnostic criteria, she's not going to be called a celiac patient by those doctors. So she's going to continue to suffer unless she realizes, hey, the treatment for celiac disease is don't eat gluten, right? But so those doctors oftentimes say, you don't have celiac disease, you can eat it. And it's like, no, that's what's destroying her. But this applies to any autoimmune disease, okay? Sue had the autoimmune process. That's what the antibodies are. She had positive tissue transglutaminase antibodies. And when those are positive, that's the target that is being destroyed in celiac disease. And so she's just, if I use a different picture from my book here to make it a little bit clearer for you, she's, oh, here's the one. Here's the one from my book with the celiac numbers, even better. So she didn't fit diagnostic criteria. She wasn't black, but she was somewhere pre-diagnosis. She had the antibodies, so she definitely was in the gray area, but how dark gray she was depends on how far along she's been. Positive
your screen didn't change.
Oh, I'm sorry. Thank you. Here it is. So this is in, do you see it now with the numbers? Okay. So this is in chapter 6 of my book, showing the latent celiac disease is you have antibodies, but no signs and symptoms at all. Okay. The inflammation is you have the positive antibodies and you're having signs and symptoms. And then the celiac disease is you have the villus atrophy on diagnostics and you fit diagnostic criteria. So Sue didn't fit black, but she fit somewhere in those 50 shades of gray there. Okay. Just antibodies is light gray, antibodies plus symptoms is darker gray, black would be diagnostic. And this applies to any autoimmune disease that we're talking about. Okay. There's many people with, say, MS symptoms that don't fit diagnostic criteria on the MRI yet, but they might have positive myelin basic protein antibodies or myelin oligodendrocyte antibodies. And so, hey, they've got the process. We can't call them, we can't diagnose them yet to stay, accurate language wise, but we don't ever want to reach diagnosis. If they've got the antibodies, that's the process that will lead to it if we don't do anything, or if we continue doing poor diagnostics and let them suffer for 5 to 7 more years until it finally shows up on the MRI. So the antibodies should be enough for you, especially antibodies plus symptoms should be enough for you to take action to address whatever condition it is that we're talking about. So yeah, thank you, Sue. That is a very common occurrence, unfortunately, because our medical system is so stuck on fitting diagnostic criteria rather than realizing, hey, you're not healthy today and diagnosable for cancer tomorrow. It takes a process for that cancer, for you to be unhealthy long enough for the cancer to develop, and then long enough for the cancer to grow to be detected. Same idea. You're not healthy today and diagnosable with celiac tomorrow. You lose tolerance, you start attacking those targets, and it takes time. Okay. Well, as that time's occurring, the process is happening, and we can catch you in process pre-diagnosis. And that's, that promotes or leads to the best outcomes. The sooner we can catch you, the better. So thank you. Good example.
One question, Dr. John. Endoscopy, will it fit in with biopsy? I mean, where does it fit in this framework?
Endoscopy?
Yeah.
That's right here, the biopsy. So EGD is endoscopy. Yep.
Yeah. My doctor recommended me this time during my annual, but the process they explained to me, I thought the side effects would be worse than just knowing what's there. So right now I've just decided not to go ahead with that.
Mm-hmm.
And listening to you, I don't know whether it would be even, can they also miss out on rectal cancer or not?
Yeah, so the endoscopy goes in through the mouth, and the colonoscopy goes up through the rectum. Okay. Yeah. And so, but yes, they can miss because neither goes fully. So there's what's called a no man's land here, where the camera stops on this end and this end that isn't covered. Okay. So in order to see that, you actually have to swallow a camera and have it go through the whole GI. Okay. So it is possible where, hey, we look here, don't see anything, look here, don't see anything, you're good. And it's like, no, the ulcer was right there, right? Where we couldn't see, or the tumor or the polyp or the whatever. And so again, every test has limitations. And so, and every test has risks as well. So, if medicine will say you should run a colonoscopy, my dad's going through this right now. Hey, it's time for your preventative colonoscopy. And he's like, well, do I really want to do this? I don't really like the idea of anesthesia and going under just for exploration, right? And so, with other things going on at hospitals these days, it's a better idea most of the time to just avoid the hospital at all costs. And so I know my dad and I know his case. So it's like, Dad, you don't have a history of ulcers. There's no family history of colon cancer. You're not an alcoholic. Like none of the things that would make us want to use the colonoscopy test specifically as a preventative measure in his case are there. So it's like, in this instance, it's probably more risk than reward in terms of the anesthesia and actually exposing yourself to the hospital and potential hospital-acquired infections and those sorts of things. So he's decided not to do it.
And just to push on that point a little bit more, is he
Mhm.
doing something similar, stool test and all, just to figure out the
Yeah,
same?
yeah.
Yeah.
So then they said, well, do the fecal occult stool test, fecal occult blood test, which is my dad, his crude way is like poop in their box is what he said,
Yeah.
right?
Yeah.
And so that test is only looking for occult blood in his stool, which occult blood is hidden blood in the stool. And if it's there, you're thinking blood coming from higher up in the GI tract. So that could be a hidden bleed of some sort. Maybe that's an ulcer or a bleeding polyp or tumor or something. Okay. If you can see blood in your stool, that could be hemorrhoids, or that's a lower GI bleed. It hasn't been in there very long. So it hasn't, hemolyzed and changed colors, but the occult blood is hidden. It's had to travel and had time to be hidden. So the fecal occult blood test can find that. But he said, I'd rather, what does your poop test show is what he says, or my stool test. And I said, well, we can see that. We can see your microbiome. We can see digestive enzymes and GI inflammation and gluten sensitivity and bacteria, worms, yeast, parasites, viruses, right? So he's like, well, I'd rather poop in your box. And it's like, okay, well, my box you have to pay for, their box you might be covered. And he said, well, I want information. I don't care what's covered, right? So he ended up pooping in my box, so to speak. And we actually found things on it that wouldn't have shown up. He didn't have any occult blood, but he had other issues that I've been telling him about for years, but your family's your worst patient, So now he'll see it on paper and hopefully be better at taking action.
How do you know? You don't
Yeah.
know.
But just to be specific though for you, a little more specific, the stool test I run won't show you polyps, won't show you colon cancer, other than if the colon cancer is causing a occult blood, or there's a gastric ulcer or stomach cancer that's causing occult blood, that would show up. But I can't see those things on that stool test, right? So the colonoscopy would go up with the camera and see the tumor growing or see the polyp and maybe see the ulcer, but they're not going to see your microbiome, which the stool test would show. So it's, again, what are the risk factors in your case? What's your specific case history, and what are the risks and benefits of it all?
Yeah, unfortunately, I have a good doctor, but I think they're trained to scare patients more than educate them.
Oh yeah.
So the way they communicate it, if you don't do it, you're running a risk.
Yeah.
And I looked at the stats and I said, I don't think I'm running a risk. So, okay, I'll hold on to year 2, 3, and then we'll just.
Well, it's like last week's video on statins, right? They've been scaring you for 35 years. And if you look at the numbers, they don't do anything, positive essentially. So, and in my book in chapter 10, I talk about, preventative testing, and as far as mammograms and prostate exams and colonoscopies, and how there's really not data showing that they're saving lives, and they may even be costing lives, depending on, how you look at the data and which tests you're looking at. So I think it should be specific, and you're looking at it specific to your case, and that's the best way to do it.